Usually, when we talk about a medical diagnosis on this dip dive, there's this expectation of precision.
Right, like a clear-cut answer.
Exactly. Like if you break your arm, the x-ray shows this jagged white line and the doctor just points to it. The bone is broken or it's not. It's binary.
It's a very clean, categorizable situation.
Yeah, and as a patient or even just looking at it, there's something deeply comforting about that visibility. You can put the problem in a neat little box. But when you step into the world of pelvic oncology and massive reconstructive surgery, that diagnostic x-ray machine basically shatters.
It completely shatters. We are absolutely no longer looking at a neat, categorized landscape.
Not at all. So you, as the listener, are about to enter what is the absolute definition of diagnostic muddy waters. This is a space where the original biological blueprint of a human body has just been entirely erased and redrawn.
It's a highly specific, honestly incredible medical reality we're looking at today. We've been going through this massive stack of clinical texts, surgical atlases, patient education materials.
And these are from major institutions.
Right,
Here.
yeah. MD Anderson, Memorial Sloan Kettering, the British Society of Sexual Medicine. And the core mission driving this deep dive is answering one really specific question.
Right.
How does surviving a radical life-saving surgery known as total pelvic exenteration, or TPE, completely rewrite the rules for how a woman's body handles mucosal moisture loss and sexual health?
And when you actually look through these surgical atlases, you realize so quickly that this isn't just a straightforward review of medical symptoms. It's not a dry textbook chapter.
No, it's intense.
It is. We are exploring the sheer extremes of human anatomical resilience here.
Yeah.
And to really grasp how TPE fundamentally alters mucosal moisture loss, I think we first need to understand what's actually being lost in the first place.
Exactly. You have to know the baseline.
Right, so think of a healthy natural vagina as a highly active, self-regulating rainforest ecosystem. It's got its own climate, its own native flora, and this constant cyclical renewal process that just hums along.
Yeah, and on a cellular level, that renewal process is driven by these superficial epithelial cells that line the vaginal walls. They're basically in a state of constant turnover.
Like shedding every few hours, right?
Exactly, every few hours. And as they shed, they release large amounts of glycogen. And that glycogen is crucial because it acts as the primary food source for lactobacilli, which are the native, healthy bacteria living in that space.
The good bugs.
The good bugs, exactly. And when those lactobacilli metabolize the glycogen, they produce lactic acid. That keeps the vaginal pH highly acidic, usually hovering below a pH of 5.
And that acidity is key, isn't it?
It's the ultimate defense mechanism. It naturally neutralizes harmful opportunistic bacteria like E. coli.
So the shedding cells are essentially like falling leaves in our rainforest analogy. They provide nutrients to the soil, they feed the healthy flora, and they maintain the exact climate required for the whole forest to just thrive.
That is a great way to picture it. And the master regulator dictating that entire biological cycle is estrogen.
Estrogen is doing all the heavy lifting.
It really is. It ensures the mucosal lining stays thick, highly vascularized, and totally saturated with that glycogen. But when a woman experiences a severe drop in estrogen, which typically happens during menopause, that entire ecosystem essentially collapses.
Right, and that collapse is what the medical texts call genitourinary syndrome of menopause, or GSM.
Right. And the structural changes during GSM are just profound. The mucosa thins out drastically. I mean, the population of those superficial epithelial cells drops to less than 10% of its baseline.
Wow, less than 10%, so the whole food source is just gone.
Exactly. Without the glycogen, the lactobacilli literally starve. Then the pH rises above 5. And that's when opportunistic bacteria can really colonize the area.
Then there's a physical change to the tissue itself too, right? Like beneath the surface.
Oh, absolutely. Beneath the surface epithelium, you have fibroblasts. Those are the cells responsible for producing collagen and elastin. But without estrogen to signal them, those fibroblasts go completely dormant.
They just shut down.
They shut down. The collagen fibers basically fuse together, and the tissue loses all its native elasticity. It becomes incredibly fragile, pale, and really susceptible to tearing and bleeding during intercourse.
Okay, so if standard GSM is like a severe drought in that rainforest, total pelvic exenteration is just an entirely different scale of event. TPE doesn't just cause a drought, it completely excavates the forest, the trees, the topsoil, the bedrock, all of it.
It's a total excavation. TPE is a surgery deployed for advanced or recurrent pelvic malignancies. We're talking about cancers that have aggressively spread or come back after initial treatments.
The absolute last line of defense.
Exactly. The procedure involves the en bloc removal of the pelvic organs. So depending on the spread, that typically means the total removal of the uterus, the cervix, the ovaries, the bladder, the rectum, and the entirety of the vagina.
Just try to visualize the physical impact of that on the human body for a second. Once all those organs are removed, surgeons are essentially left staring at this massive, non-collapsible, bone-lined void right in the center of the patient's pelvis.
Right. And because the pelvic cavity is bordered by rigid bone, the surrounding structures can't simply, shrink or compress down to naturally fill that gap.
So you just have this massive crater.
Massive crater. And leaving it empty results in this highly dangerous anatomical crisis known as empty pelvis syndrome.
Which sounds terrifying just by the name.
It is. If that space remains unfilled, severe complications just cascade rapidly. Fluid begins to pool in the dead space, which creates this perfect breeding ground for massive infections.
And doesn't gravity start playing a role too?
A huge role. The small bowel can literally prolapse, basically fall down into that empty pelvic cavity.
Mm-hmm.
And once it's trapped down there, the bowel can twist or adhere to the pelvic floor.
Oh my gosh.
Yeah, that leads to bowel obstructions, perineal hernias, or even the formation of fistulas.
And a fistula is basically an abnormal channel, right?
Right. It's a leaking channel that can open up between the bowel and the skin. It's incredibly severe.
Okay, so obviously, surgeons are forced to fill that void. They have to engineer a completely new landscape. And this reconstructive phase is precisely where the entire clinical concept of mucosal moisture loss gets turned completely on its head.
Totally flipped upside down.
Because if you're reading through these operative reports, you see that reconstructive surgeons have to bring in foreign tissues from entirely different geographic regions of the body just to build a new pelvic floor. And, if the patient opts for it, a neovagina.
And the surgical atlases we reviewed detail a variety of these ingenious, if really extreme, solutions.
Extreme is definitely the word.
Yeah, surgeons will frequently use what's called a gracilis myocutaneous flap that involves harvesting muscle, fat, and skin straight from the inner thigh.
The inner thigh,
Right.
okay?
In other cases, they might utilize a VRAM flap, the vertical rectus abdominis, where they actually pull down the abdominal muscle.
Like the stomach muscle.
Exactly. Or they might use resected segments of the colon, or even something called an omental J-flap, which involves pulling down this highly vascularized fatty apron from the stomach lining.
Okay, but if you were listening to this right now and wondering how a piece of inner thigh muscle or an abdominal wall is supposed to function as a vagina, you have hit on the exact physiological crisis these patients face.
Because it's not a vagina.
Right. We aren't really treating mucosal moisture loss in the traditional sense anymore, are we? We are taking a completely foreign architectural material muscle or stomach tissue and trying to force it to behave like a mucous membrane.
And the biology simply does not map over. It just doesn't. A neovagina constructed from a thigh muscle flap possesses an entirely different cellular identity.
It doesn't have the right hardware.
Exactly. It lacks the estrogen receptors found in natural vaginal mucosa. It does not contain those glycogen-rich epithelial cells we talked about earlier.
Yeah.
Therefore, the tissue physically cannot self-lubricate, and it cannot support that acidic, self-cleaning lactobacilli ecosystem.
And the patient education materials, like the ones from MD Anderson, they are starkly honest about this new reality.
They have to be.
Yeah, their post-operative guidelines explicitly state that because a neovagina cannot cleanse itself, the patient will need to manually douche to prevent the buildup of discharge and odor. The self-cleaning mechanism is just completely gone. You have to physically go in and wash the synthetic environment.
And the subsequent impact on sexual health is exactly as challenging as you might expect.
Yeah.
There was this really eye-opening study published by the UT-MD Anderson Cancer Center. They evaluated 44 patients who had undergone vaginal reconstruction using that gracilis thigh flap.
The inner thigh one.
Right. And the data showed that over half of these women, 52.5% to be exact, never resumed sexual activity post-surgery.
Wow, over half.
Over half.
Yeah.
And for those who did attempt to resume intimacy, severe vaginal dryness and persistent discharge were cited as the most common, intractable hurdles they faced.
And we really can't ignore the compounding devastation of radiation therapy here either, because almost every single patient undergoing a procedure as radical as TPE has also been subjected to intense pelvic radiation.
Oh, absolutely. Either to shrink the tumor prior to the surgery or to eradicate microscopic disease afterward.
Right, and radiation fundamentally alters the DNA and the vascular architecture of tissue. Like normal vaginal epithelium, because of its rapid cell turnover, is notoriously sensitive to radiation toxicity anyway.
But the damage extends to the imported flap tissues as well. That's the crazy part.
Oh, right, because you're bringing fresh tissue into a radiated zone.
Exactly. When you bring a healthy thigh muscle into a heavily irradiated pelvis, it suffers from what we call late radiation tissue injury. And this is a process that can unfold over months or even years.
It's basically a delayed reaction.
Right. The tiny blood vessels supplying that flap undergo something called endarteritis obliterans.
Okay, break that down for us.
Basically, the blood vessels literally narrow and close themselves off over time.
So they just pinch shut from the radiation damage.
Yeah, they just obliterate their own blood flow.
Hmm.
And this lack of blood flow triggers widespread fibrosis, which is this dense internal scarring. The tissue becomes incredibly rigid, it gets starved of oxygen, and it becomes highly susceptible to necrosis, essentially dying off.
Which eventually leads to vaginal stenosis, right? Where the physical canal just violently contracts and narrows.
Yes, stenosis is a huge issue.
So it's obvious that the standard treatment playbook for moisture loss is just entirely useless here. Like, if a patient comes in with typical genitourinary syndrome of menopause, a doctor has a standard set of biological levers they can pull.
Right, they have options.
They might utilize vaginal laser therapy, for example.
And laser therapy for standard GSM is highly effective because it relies on the body's native repair mechanisms. The laser basically targets the residual water molecules within the connective tissue, and it generates a precisely controlled thermal edema.
So it creates like a micro injury with heat.
Exactly. And that acute swelling jolts those dormant fibroblasts awake, forcing them to rapidly synthesize fresh collagen, elastin, and new blood vessels. It literally forces the existing biological machinery to reboot.
But if your anatomy is now built out of an irradiated rectus abdominis muscle, firing a laser at it isn't going to wake up anything because the biological machinery of a mucosa was never there to begin with.
It's a totally different tissue type.
So if treating standard GSM is like watering a garden to revive a dormant root system, treating a post-TPE neovagina is more like maintaining a highly specialized, sensitive synthetic turf.
That is the perfect analogy. The biological water source is permanently eradicated, meaning treatment becomes this lifelong regimen of manual mechanical conditioning. The clinical guidelines stress that first-line defense relies entirely on exogenous non-hormonal moisturizers.
Right. We are talking about polycarboxyl-based or hyaluronic acid-based gels or these specialized vitamin E inserts, and this is not a casual, as-needed recommendation.
No, it's a strict protocol.
Patients have to adhere to a schedule, applying these moisturizers 3 to 5 times a week, usually at bedtime.
And they do it at bedtime to allow the foreign tissue maximum time to actually absorb the hydration without gravity working against it. And then during any sexual intimacy, massive amounts of exogenous lubrication, water, oil, or silicone-based are just an absolute mechanical requirement.
Just to prevent sheer friction and tissue tearing.
Exactly. And you'll notice the heavy reliance on non-hormonal interventions there.
Because of the cancer risk, right.
Exactly. Systemic hormone replacement therapy is heavily restricted. It's considered only if it is definitively oncologically safe, meaning it absolutely will not inadvertently feed a hormone receptor-positive cancer.
Right, though I did see in the sources there is level IC clinical evidence supporting the use of localized topical estrogen just to mitigate some of the acute radiation changes.
There is, yes. But applying estrogen to a thigh muscle flap will never transform it back into a self-lubricating mucosa. It might help with the radiation damage, but it doesn't change the tissue type.
And because of that progressive radiation fibrosis we were talking about, the synthetic turf requires way more than just hydration. It requires intense physical architectural maintenance. Patients are prescribed vaginal dilators.
Yeah, the clinical guidelines provide level IIC evidence for regular dilation. These are smooth, graduated cylinders that absolutely must be inserted manually by the patient on a frequent, regular basis.
Because they have to physically combat the scar tissue.
Right. The mechanical pressure physically stretches the fibrotic tissue, forcing the neovagina to remain patent or open. If a patient neglects this mechanical dilation, that heavily scarred, irradiated flap tissue will relentlessly contract until the canal is completely closed off.
But here's where it gets really intense, because even with strict adherence to moisturizing and dilation, sometimes the tissue simply fails.
It does. The radiation damage is just too overwhelming.
The reconstructed anatomy becomes completely rigid. And when you read the clinical case studies on this, you realize that when this happens, surgical oncologists have to fight the complications of surgery with even more extreme, highly experimental surgery. We basically enter the surgical frontier of moisture and elasticity.
Yeah, there is a particularly striking case study in the literature that really highlights this. It details a patient whose neovaginal introitus, the external opening, suffered such severe radiation toxicity that it transformed into a rigid, non-yielding fibrotic ring.
Just a solid ring of scar tissue.
Yes, the lack of elasticity was absolute. The opening was permanently fixed, which caused excruciating pain, even when the patient was just, simply sitting down in the chair.
Wow, so making any form of intercourse completely physically impossible.
Entirely impossible.
And all the exogenous gels and dilators in the world cannot fix a rigid ring of scar tissue like that. So the surgical team utilized something called structural fat grafting, specifically adapting the Coleman technique. And if you think about the physiological logic here, it is just astounding.
It really is.
The solution to a complication from a massive organ removal surgery is essentially to perform targeted liposuction, process the fat, and inject it into the pelvis just to mimic the elasticity that the body can no longer generate.
And the biological mechanics of fat grafting explain exactly why this is necessary. Adipose tissue fat is densely packed with adipose-derived stem cells and critical growth factors.
It's like liquid gold for healing.
Exactly.
Yeah.
When you inject this into an irradiated, oxygen-starved environment, those stem cells actually trigger neovascularization.
Which means they command the body to build new blood vessels.
Right. They actively reverse the radiation damage and soften the fibrotic scar tissue. So for this specific patient, the surgical team injected 200 cc's of a tumescence fluid into her thigh to prepare the donor site, and then carefully extracted the adipose tissue using manual, low-pressure liposuction.
But you can't just inject raw, unprocessed thigh fat straight into a damaged pelvic floor, right? The purification process is where the real medical engineering happens here.
Yeah, it has to be highly processed. The harvested fat is immediately placed into a centrifuge and spun at exactly 1,800 revolutions per minute for 3 minutes.
Wait, they literally spin it at 1,800 RPM.
Yeah, exactly, for exactly 3 minutes. And the specific centrifugal force stratifies the tissue into 3 distinct layers. You get a top layer of unusable oil, a bottom layer of blood and fluid, and then this vital middle layer.
And that middle layer is the payload.
It is. That middle layer contains the pure, intact, living adipocytes, the fat cells that hold all that regenerative power.
And the crazy part is, the surgeons extracted a mere 20 milliliters of those purified fat cells. They didn't just flood the area with it, they injected those cells literally drop by drop, using a highly specialized cannula in a fan-like pattern directly into the rigid, damaged vulva and the walls of the neovagina.
And that fan pattern is highly deliberate. By depositing microscopic droplets of fat across a wide area, the surgeons ensure that every single transplanted adipocyte has the maximum surface area to connect with whatever sparse blood supply is left in that hostile irradiated tissue bed.
Because if the fat cells don't hook up to a blood supply fast, they just die.
Right. If they don't revascularize quickly, they die and the whole graft fails. But in this case, the results were just extraordinary. 11 months post-operation, the clinical assessment showed marked improvement in tissue elasticity, a significant softening of the skin quality, and a total resolution of the chronic irritation.
It's an incredibly innovative salvage procedure. Yet, the sources document even more extreme interventions for when the reconstructed tissue completely breaks down. Like, we're talking about massive anatomical failures, like the development of a vesico-intestino-vaginal fistula.
Yeah, a fistula of that magnitude is catastrophic. It means the surgical reconstruction has failed to the point that wide abnormal channels have opened up between the bladder, the intestines, and the neovaginal cavity.
So all of those systems are just cross-contaminating?
Yes. The patient is essentially leaking urine and fecal matter continuously. In one documented case in the literature, a patient was losing a liter of fluid every single day directly through the vaginal vault.
A liter a day. That is just, I mean, when a patient has already endured TPE, Their abdomen is already a war zone of scar tissue. Surgeons can't simply harvest another thick abdominal muscle flap to plug a hole like that.
No, they've run out of donor sites in the abdomen.
So in this case, a multidisciplinary team had to pivot to what's called a split-thickness skin graft, or STSG. They shaved a microscopic layer of skin from the patient's leg and physically paved it over the exposed, fluid-leaking intestinal tract at the top of the vaginal cuff.
And integrating a delicate skin graft inside a highly irradiated, aggressively leaking internal cavity is notoriously difficult.
I can't even imagine. It's too wet, right?
Exactly. A skin graft requires continuous firm pressure against the tissue bed to allow new blood vessels to bridge the gap.
Mhm.
So to achieve this, the surgeons deployed a vacuum-assisted closure device. They inserted a specialized vacuum sponge directly into the neovaginal cavity, sealed it completely, and applied continuous negative pressure for 4 days.
Imagine the physical reality of that for the patient. A vacuum sponge is placed inside the reconstructed pelvis to physically suck away the leaking fluid, all while forcing a piece of leg skin to fuse with the intestines.
It's wild. But the negative pressure from the vacuum device simultaneously removes the excess exudate that would otherwise drown the graft, while the physical suction actually promotes rapid angiogenesis, literally pulling new blood vessels into the grafted leg skin.
And it worked, right?
It did. The intervention was successful. The massive fluid loss was eventually reduced to less than 50 milliliters a day.
When you look at the sheer scale of these interventions, centrifuging stem cells to rebuild elasticity, deploying internal vacuum sponges to force leg skin to heal over intestines, you really realize how inadequate a phrase like treating vaginal dryness is in the context of total pelvic exenteration.
It doesn't even come close to covering it.
No, we are light years away from prescribing a hormone cream.
Totally. Surviving this procedure demands an absolute paradigm shift from the patient. You are forced to abandon the entire concept of a self-regulating biological ecosystem.
It's gone.
It's gone. The anatomical reality is now a landscape of foreign tissues relocated from the thigh or the abdomen, struggling to survive in a heavily irradiated environment. The clinical objective shifts completely away from rebalancing hormones.
Right. Instead, the patient has to embrace this lifelong, highly proactive regimen of mechanical dilation, intense exogenous moisturizing, and the very real possibility of secondary reconstructive surgeries just to maintain a baseline of structural integrity and daily comfort. It is a profound testament to both medical engineering and the incredible endurance of the patients who have to navigate this new anatomy. And, to wrap up our deep dive into these surgical texts, there's one final, really mind-bending fact buried in the data that I think fundamentally challenges how we understand the human body and sexual response.
Yeah, this part is fascinating. It connects back to the reconstructive flaps we talked about, specifically the omental J flap.
The stomach one.
Right. When surgeons reconstruct the neovagina by pulling down the omentum, that fatty apron attached to the stomach lining, they are repositioning tissue that is innervated primarily by the vagus nerve.
And physiologically, the vagus nerve regulates internal organ functions like digestion and heart rate. Under normal circumstances, tugging or applying pressure to your stomach lining does not generate any sensation of sexual pleasure.
No, not at all. It is purely internal autonomic tissue.
Yet, the surgical outcome data reveal something absolutely astonishing here. Approximately 40% of patients who have their neovagina constructed specifically from this omental stomach tissue report experiencing sexual orgasm.
Which is just incredible. It forces you to question the rigid mapping of human neurobiology. I mean, if mechanical stimulation of repositioned stomach tissue can be translated by the brain into sexual orgasm, how much of human intimacy is strictly dependent on the localized anatomy we are born with?
Right.
And how much of it relies on an incredibly fluid, adaptable neural map in the brain? A brain that can somehow dynamically rewire itself to extract genuine sexual pleasure from a repurposed piece of the digestive tract.
It's staggering to think about. That is a profound biological mystery to leave you with as we close out this deep dive.